Thank you for this opportunity to present at this meeting. My disclosures are on this slide. As I sit around and listen here, I'm kind of confused. Are we doing ready, fire, aim, or are we doing ready, aim, fire? And I think we want to do ready, aim, fire, and as we're learning, we don't know what we're firing that many times. Sometimes you also think you might have the cart ahead of the horse, and again, that worries me with what's going on. We need to get better. This is, that didn't work, but anyway, this is called the world's shortest vacation. And if we don't do this right, this is what's going to happen. So I want to give you our journey. We treated our first patient with targeted focal therapy called a lumpectomy in 2006. How did we get there? We didn't want to do any harm, so we studied patients ahead of time. What we had is something nobody else had. We had 160 autopsy cancers, people that died in a VA hospital not knowing to have cancer, that we did whole mounts on, 3D reconstruction and things like that. Plus we had over 350 radicals. We studied these 3D models using the template that Winston Barzell put together a number of years ago, and found out that, in fact, you needed to do 5 millimeter sections, not 10 millimeter. And we published on this in '98, and Priya Warahara, who's also here in the group, published in 2003, that to do this accurately and to mimic and find all the significant cancers, you need to do 5 millimeter intervals. So we published on also, several years later, on our first 350 patients we treated, that we did mapping biopsies on, and many of them got targeted focal therapy. I mentioned this earlier, that approximately 50 men who had disease that was more extensive underwent a radical prostatectomy, and the correlation was nearly 100% of the mapping biopsies with the radical prostatectomy. So we think that this is sort of the gold standard. So we know that we have ultrasound. We've been using that for a long time. We have MRIs. We've had some very nice discussion of the pros and cons of MRI. But we have heard that MRI can miss clinically significant cancers anywhere from 6 to the worst being 47%. And we also heard that the technology is in evolution, and that it takes a very good radiologist to read these, and we've got a long way to go. So let's talk about something that might be comparable, and we'll show you some of our work with mapping biopsies with this. The ExactView micro-ultrasound machine basically is our old standard ultrasound machine on steroids. It's 300% more magnification. It's 29 megahertz. It has a resolution as you can see, where's the pointer here, of 70 microns, and you get both axial and transverse views. So this is an example. Even I can see this lesion right here in the prostate, and also you sort of get one-stop shopping because you can biopsy the lesion at the time you see it. Now, what about comparing this to MRI? There's only been a few cases. This is one case report of someone that had a MRI and a micro-ultrasound and a radical. And they use a system called Primus, which is a little different than PIRADS, but it gives you relative risk of having a higher grade cancer. And this is the histopathology between the Primus 4 and 5 lesions, which are the ones that are the higher risk, as we can see right here. So what did we do? I want to talk to you about 3 patients, and that's not a big series, who underwent the micro-ultrasound and then underwent mapping biopsies. So we know that what mapping biopsies can do, so we want to see how micro-ultrasound would do. So there were 3 men, age 60 to 74, PSAs, as you can see here, 1.9 to 6. We also had one person who had an outside MRI that showed a right peripheral zone lesion. So here's the Primus system. 5 is highly suspicious, 4 is suspicious, and 3 is equivocal. They have the Exact View folks have a very great educational program on their website that goes through teaching you all this stuff, and there is a learning curve. So you have a suspicious lesion that you can see right there. So what we did was we overlapped what these were on the micro ultrasound, and then we compared them to what was present in the mapping biopsy. So here is the sort of the 3D reconstruction of the micro ultrasound, and this is what we found in the mapping biopsies, as you can see here in an axial view. And this was also that one person that had a PIRADS 5 in the apex. You can see it right here on our mapping biopsies, but also the micro ultrasound also overlap very nicely with these things. So I think what we can say is that there was a reasonable correlation. This is a very busy table, but it goes through all the lesions that were found and then the outcomes here, and it picked up everything significant. There were a couple of grade group 2s that were like 0.5%, 0.1 cc, I'm sorry, that were located anteriorly or that were missed, and we didn't think that was significant. So the correlation was very good. This, I think, is something that's interesting. We've heard a bunch of talks about cryotherapy. Look at the views you get here with the micro ultrasound of the rectal wall, of the lesion, seminal vesicle invasion, and then we saw one area here where there was perforating through the capsule that was not seen on our standard workup, and here it is right here, another view. Look at the ice ball. This is the ice ball with cryotherapy. You can see the seminal vesicles, the rectum. You get a lot better view using this when we do with our standard ultrasound, and this is when it was done. And here's that lesion that was seen beforehand. This is it afterwards. Yes, we paid attention to it and treated it. Whether we got it all, I don't know, but it was an interesting finding. So in conclusion, what we can say is that the Exact View microultrasound demonstrates potential clinical utility for the diagnosis of high-grade prostate cancer. Primus 4 and 5 are consistent with higher grade groups, and it may be you can use it with MRI for fusion biopsies, or if you see something, you can target it right away. The micro ultrasound is undergoing a lot of evolution with now being able to get transverse sections and things like that. So with that, somehow my last slide, thanking our group is not here, but I appreciate all the group at the University of Colorado and that have worked with us to develop this. Thank you.